Good morning. We're going to start on time as people drift in. I'm Steve Hinshaw, Vice Chair for Child and Adolescent Psychology. Very pleased to introduce our distinguished visiting speaker for this month, Professor Sherry Glied, who is Dean of NYU's Robert F. Wagner Graduate School of Public Service. This is her building on Houston Street in New York. Professor Glied received her BA in Econ from Yale, her MA in the same field from Toronto, and her doctorate in economics from a small school called Harvard back on the East Coast. Previously, she was chair of the Department of Health Policy and Management at Columbia's Mailman School of Public Health, also back in New York. She is an academic with a distinguished history of public service. In fact, in 2010, she was confirmed by the U.S. Senate as Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services, serving for 2 years in that role for the Obama administration. I know her and her colleague Richard Frank best for their classic book, Better But Not Well. She's published several other books and countless articles in the field of health economics and mental health economics. She's going to give us a grand tour of the field today. Please welcome Professor Sherry Glied.
All right. Thank you very much, Dr. Hinshaw, and thank you for inviting me to beautiful San Francisco. It's so beautiful out here. So I want to talk about a long-standing tension in mental health policymaking and how it manifests over time, which is really the tension between what Richard and I call mental health exceptionalism. That is, policies that are designed specifically to focus on people with mental illness, and the mainstream of health policy, which is policies that are essentially agnostic to mental illness. And this morning I woke up in my beautiful hotel in beautiful San Francisco, and the San Francisco Chronicle actually had this story in front of me because they had 2 articles about mental illness. One of them you probably wouldn't have noticed was about mental illness, even if you read the San Francisco Chronicle. But the first article on the front page of the paper is that the city of San Francisco wants to expand mental health treatment and pass some sort of legislation and do something. And then on the last page, there was a piece about the Governor Newsom's plan to extend Medicaid, which is really a mainstream kind of policy. And so this talk is really very much about that tension between what San Francisco is thinking about doing around mental health specific interventions and what the state of California is thinking about doing around broad, wide Medicaid expansion. And so it's a perfect moment. So I want to talk about exceptionalism in the mainstream and talk about the Affordable Care Act a little bit, and then talk about some challenges going forward. So I actually want to start off by talking about why we even have this conversation. Why isn't mental health firmly in the mainstream of health policy to begin with? Why do we even have this challenge? And I think there are sort of 3 sets of reasons. One of them is what in economics we call asymmetric information. That is, it's very hard to know, for one person to know what the other one, what is in the other person's head. And that is particularly true in mental health because there is no lesion, there's poor observability of the condition. And if you think about the problems that we face in policy, mental health policy generally, which are often about how much treatment should people be able to get, or should people be entitled to, or how much are people going to have to pay for the treatment that they receive, a lot of those tensions are around this problem of poor observability. We don't have the same problems in conditions where we can see on a meter whether you've gotten enough of your drug or not, right? Second, because of the behavioral responses. So because of the nature of the illness itself, our general health system is predicated on the idea that patients are very important agents in the control of their own treatment, in making decisions about their own treatment and so on. But when we talk about mental health, we're talking about conditions that by their nature impair people's judgments, and that we need to balance people's needs as viewed objectively or viewed externally with people's needs as viewed by themselves. And that tension is also distinct from other parts of health services. I want to stop, though, and note that none of these things are, this break is not clean. There are many health services that have similar characteristics. Richard Frank and I often say mental health has all the problems of the healthcare system except more so. So it's really a continuum, and mental health falls on that continuum at sort of at the extreme. The third piece of this, and very much you can see it in the San Francisco story, are the external effects of mental illness. So one set of external effects around the family members of people with mental illness, and a second set of external effects on society broadly, which may take the form of external manifestations that people find disturbing, which is really what you see in San Francisco. The reason for this big effort to expand mental health is not purely out of altruism about people with mental illness. A lot of it is about making San Francisco a more desirable place for everyone else. And so there is a concern about the disruptive or disturbing behavior of people with mental illness, and then the manifestation of that in stigma, the sort of the flip side of that, the stigmatization of mental illness. So for all of these reasons, we have long had an exceptionalist mental health policy. This is New Bethlehem Hospital from 1620. I don't think this picture is from 1620, but you have this system of care and control, however you want to think about it, for people with mental illness that arises in parallel to and often quite disjunctive from the system of policy and institutions for people with general health problems. Okay, so first big effort in the U.S. to try and reconcile these two strands of policy comes when John F. Kennedy gives this speech back in, I got to get the date right, February 5th, 1963. And Kennedy gives a speech about restoring people with mental illness from institutions back into the community, really bringing people back into the mainstream to improve the level of care, but to return people to the community, to restore and revitalize their lives in the community. And this big push really from then on in the policy thinking about restoring people into the mainstream and out of the exceptionalist mental health system. And in fact, that's what happens in a certain way. If we look at deinstitutionalization and Kennedy's speech, which is the second dot there, you can see that you really do see this big plummeting of institutionalization. It begins, you can see that institutionalization peaks in 1955. The first antipsychotic drugs come along, and deinstitutionalization starts at a moderate speed until here. And you might think that that is the moment of John F. Kennedy's speech, which would be a lovely thing. That is not, in fact, the precipitating moment here. Precipitating moment is a mainstream moment. It is the passage of Medicare and, most importantly, Medicaid. So what does Medicaid do? What Medicaid does is it says to states, listen, if you are willing to care for people with mental, if you want to care for your poor people, indigent people in your state, the federal government will pick up part of the bill. But by the way, you've already built this system out there, Bedlam Hospital and so on, your exceptionalist system for mental illness. We, the federal government, we're not going to pay for that. So if you have people who are stuck in those institutions, we're not paying for them. If you take them out of those institutions and put them somewhere else, the federal government will foot half the bill. Well, remarkably, when states saw that they could get a 50% discount on the cost of people with mental illness if they were outside of institutions, they very rapidly found a way to get them out of institutions. Now, it is important to note that mostly they did not deinstitutionalize the seriously mentally ill in this period. That is not mostly what was happening. What was mostly happening is that elderly people who were confined to mental institutions because of dementia were transferred to nursing homes. Nursing homes did not fall under this rule because they were not the descendants of Bedlam. And so when you trans-institutionalize people from mental hospitals into nursing homes, you were actually able to get some of that Medicaid money. But eventually it also moved people with serious mental illness into the community and so on. So this process of deinstitutionalization is very much the process of the mainstream affecting mental health policy. We can see this more directly in this chart, which looks at financing. And this is where does the money that pays for mental health care come from? I've updated these slides, but you can see here, okay, we'll go back. You can see here that if we look at the leftmost part, this is 1956, just at the moment at the peak institutionalization, nearly 60% of all the money in the mental health system is coming from state funds, pretty much paying for inpatient psychiatric facilities, usually located in bucolic rural areas far away from the people who didn't want to be disturbed by the seriously mentally ill. Some of the money is coming from out-of-pocket payments by individuals. At that time, I should get the number right, but something like a third of the psychiatrists in New York, in the United States, lived on the island of Manhattan. Still feels that way sometimes. And they were being paid out of pocket for psychiatric psychotherapy. And then there's a last chunk of it. This is other federal money. What you don't see here is any insurance coverage, because there is no insurance coverage for mental health in 1956. So 1971, post-Medicaid and Medicare, you can see a very big change here. So there's more out-of-pocket money, true. There's also private insurance, but here is Medicaid and Medicare picking up a chunk, really, of the state money as the deinstitutionalization happens. As we move along, that out-of-pocket shrinks, insurance picks up more, Medicaid picks up more, the state money goes lower, and by 2016, Post-Affordable Care Act, about two-thirds of the money in the system is now insurance money. It is not money that is going to institutions. It is money that is traveling with people. So it's going to make very big changes to the whole structure of the mental health system, that the money moves with the person rather than going directly to the provider. And again, if you think about about the San Francisco plan, you can see how it is in some sense an exceptionalist plan, because again, it's focusing a little bit more on paying the providers, and rather than having the money travel with the people. Okay. Ugh. So you can see the big increase in Medicaid post-ACA. So in our book, Richard and I are trying to look at how all these changes affect people with mental illness. And we take a very long view. We're looking at 1950 to 2000 in the book, and I'm going to show you some numbers that bring it up to date to about 2016. We try to look at across the entire population. So we try to do something in the book that's kind of fun, which is, I don't know, I have a weird idea of fun. I have 3 degrees in economics. What can I tell you? So most people look at a question like, what percentage of people in prison have a mental illness? That's a standard kind of question. We wanted to ask the opposite question, or sort of the inverse question, which is, of people with mental illness, what fraction are in prison? And that's not a question we normally ask, because we don't really have a census of people with mental illness that we could do that from. So we make a kind of heroic assumption in the book, which we base on a variety of epidemiological studies, saying that let's assume that the share of the population that has a mental illness is not changing dramatically over time. And at least for the people with a serious and persistent mental illness, that seems likely to be true. There's more change here, but in this population, if you look at the population with schizophrenia and bipolar disorder particularly, that's a pretty constant fraction of a given population. So we can say we know that there are about 3.5, 4 million people with these conditions. Where are they? Can we identify where they are? And that's what we really try to do in the book. So what we conclude in our book, and I think even more so going forward, is that the well-being of people with mental illness has improved substantially over time. And that may seem like a strange thing to say, because people with mental illness are still among the most vulnerable and disadvantaged in our society, which is the reason that the title of the book is Better But Not Well. But I think it's important to focus on the better, because if we don't understand why things have improved or what policy has done until now, we're unlikely to make changes in the future. So the question is, if we say better but not well, where does the better come from? Now, if I were giving this talk at the cancer grand rounds, the answer would be really straightforward. And the answer would be, in 1950, we had no idea how to treat any forms of cancer, or very little, and now we have all sorts of new drugs and treatments and so on. That is not the story in mental illness. So are there new and better treatments? Not so much. We have some new and better treatments, but for most conditions, clinical trials suggest that new treatments are not much more effective in alleviating symptoms than earlier treatments. This is not a field in which we have seen dramatic improvements in psychopharmacology or in other forms of treatment, which is very disappointing and would make an enormous difference, but I think really does make it even more surprising and encouraging in some ways that we have seen improvement in terms of people with mental illness. So where has the improvement come from? Well, one important place it's come from is that more people have access to treatment. If you think about that picture back in 1955 that I showed you earlier, where most of the money was flowing to state mental hospitals, the only people who were getting any treatment were some small fraction of the people in those hospitals. Why do I say some small fraction? Because those hospitals were mostly not, we call them hospitals, they were mostly not hospitals. They didn't actually provide much treatment. Many of them had almost no professional psychiatrists or psychologists on staff. I remember reading the big case in South Carolina, whatever. There was one part-time psychiatrist and several thousand people living in the hospital. There was nothing in the way of treatment for most of them. And if you were not living on the island of Manhattan, you didn't have much access to psychotherapy either. So there wasn't really anything happening with respect to treatment. What we see over time is that the fraction of people receiving treatment is going up. The last numbers are from a different survey than the others, so it's a little bit more surprising, a little hard to compare. But there certainly is a big increase in treatment between 1990 and 2001, and some increase through 2017 as well. I will note in the better but not well mode that it still looks like at least 30 or 40% of people with serious mental illness are not receiving treatment in a given year. So the scope of treatment has expanded, but it hasn't reached everybody by any means. Second, there's some evidence that the quality of care that people have been receiving has also been improving. So we look at guideline concordant treatment. We take current guidelines and look at how they were implemented in the past, because that's what we're trying to figure out. And the answer is more people are getting treatment that is concordant with guidelines. Part of the reason for this is that we are doing a better job of documenting things and actually looking back to see whether people are in fact adhering to guidelines or not. It's a big headache for people, but it does improve life for researchers. So quality has been improving for schizophrenia. And then if we look at some other disorders and trying to see how people are doing, there's more evidence of people getting dosages of treatment effectively that seem to be more likely to be effective. Fewer people using low doses of psychopharmacology that probably are not helping them, and more people receiving the right kinds of medications. So again, these are not new medications so much as more appropriate receipt of drugs that already existed. And a very important part of progress in mental health, which has now piqued people's interest, and they're talking about the same thing in other areas of medical care, is what we call ex-innovation. So one of the things that happens in mental illness is that we do learn that some things that we thought might work don't work, like psychosurgery, and we stop doing them. And that probably makes people a lot better off. So experimentation is a good thing. One of the challenges is that things don't actually necessarily ex-innovate after people have learned that they don't work. We do see here some evidence that treatments that were found to be not effective have declined, and things like ECT, where we know it's now effective for some people in some circumstances, are being used in more appropriate ways than they had been. So quite a bit of evidence that there have been improvements on the clinical side, but there have been even more substantial improvements in other aspects of the lives of people with mental illness. Probably the first important one is financial protection, out-of-pocket protection. Because mental illnesses often begin or manifest when people are relatively young, they have had really terrible financial implications for families. The presence of a child with a serious mental illness can be a bankrupting event for many families. And for people who are older and develop mental illnesses, the out-of-pocket costs of getting care can be really limiting. What we see over time is the share of expenses that are paid out of pocket among people with a diagnosis. And you can see here that there have been consistent improvements in that share over time. People are paying a smaller share of their prescriptions. They're paying a smaller share of their non-physicians, so that would be psychologists, social workers, those visits for their physician visits. Despite the increased number of psychiatrists who are out of network and so on, you're still seeing overall reductions in out-of-pocket payment. And for hospitalizations, which are really the most costly of these, you see that most of the cost of psychiatric hospitalization is now being paid by insurance coverage, which is a major gain for families, especially who have children with mental illness. May also have contributed to the improvements in quality that we see earlier. So one of the differences between funding things in the exceptionalist way and funding things in the mainstream way is who gets to choose what treatment they're getting. when we fund things through insurance and people have a choice about providers, you might imagine that that helps, this is a hypothesis, we have not tested it, in the rate of exnovation of things that are at least ineffective and disturbing. Maybe not in the list of things that are ineffective and not disturbing. So you could imagine that insurance may be a contributor in this way to improvements in quality. So the final thing that we look at is the resources that are available to people with mental illness. And here I think this is probably our most audacious claim in the book, that the living circumstances of people with mental illness have actually largely improved. Again, that better but not well line is very important here. And this is almost entirely due to changes in mainstream policy. So in 1972, about 31% of people with serious mental illness were receiving food stamps. Our latest numbers were in 1998, because it's hard to get these, 63%. Medicaid, it's much higher than that now. SSI, the supplemental security income, has been, I'll come back to that in a second. SSDI and Section 8 housing, more and more people have access to resources. Now, why is this important? Well, deinstitutionalization, people had focused a lot on the importance of getting care in the community. And for sure, that is really important. But if you're talking about a population that is being deinstitutionalized from psychiatric hospitals were total institutions. They not only provided people with whatever care they needed, if they were providing care at all, but they provided them with shelter and food and things like that. So if you deinstitutionalize somebody and only give them access to medical care, you have come nowhere near to addressing the problem. So one of the things that made deinstitutionalization really possible was the existence of things like SSI and SSDI that provide income to people who are disabled to live in the community. And I think one important group that it provides income to is family members of people who are disabled, so that they can remain home and not have to work and provide care for people. So SSI and SSDI have been really instrumental in mental health policy, although nobody working on those programs was thinking about mental health at all. So if we look down this list of programs, none of them is a mental health program. Nobody had thought about mental health in thinking about these programs. Okay. So what has that done? This is the share of people receiving SSI or SSDI over time. You can see it going up. And what it has done is it has increased the fraction of people with serious mental illness whom we can track as living in the community or with their families, or in some other location that we can track down. So what you can see here is institutionalization really drops off, and the substitution is really often into people who are living on their own in the community or who are living with their families in the community. And that is very much a function not of exceptionalist policy, but of mainstream policy that is enabling people to live out there. So today, about 84% of people with serious mental illness are living in the community or with their families, even at the height of institutionalization. So here's another point. People blame deinstitutionalization for everything. Even at the height of institutionalization, only a very small fraction of people with serious mental illness were in institutions. There was no way we could keep 4 million people in institutions. So even then, a lot of people were living in the community, but they were living with even fewer resources than the resources that they have today. Okay. So things are better. There are still fewer people in the institutions. However, things are not well. And again, this is in large part a consequence of mainstream forces. So this has been debated back and forth a million times. Do you all know Steve Raphael? He's here, right? He's at Berkeley. Oh, he's at Berkeley. That's not quite here. He's done a lot of work on this. Okay, so what has happened? We have, in the same period, seen a big rise in two very bad social pathologies, homelessness and incarceration. Neither of these things, it has now been carefully documented, are mostly due to deinstitutionalization. Some people find a small fraction of them is due to deinstitutionalization. Some people find none of the fraction. We've all heard about the big rise in incarceration in the U.S. That's an easier one to argue. Okay, the war on drugs, all of the bad stuff that all the Democratic Party candidates have to deal with these days, right? That increase in incarceration picked up a lot of people with mental illness, and it kept more people with mental illness in prison. So people with mental illness were in the population that was likely to be incarcerated, and they were incarcerated at increasing rates. It is not the case that incarceration was a consequence of mental illness. It is much more the case, or not entirely the case, it is much more the case that the rise in incarceration swept up large numbers of people with mental illness because they were there to be swept up. If you think about a war on drugs and you imagine who the people are who are low-level drug users on the streets, a lot of them are people with mental illness who are going to be in that catchment and pulled up. When you think about fixing broken windows, quality of life crimes, things like that, that is going to be picking up a lot of people with mental illness. So yes, there is this debate about whether incarceration leads to, whether deinstitution leads to incarceration. The evidence suggests it's only at most a very small piece of it. Likewise with homelessness. So as we see a rise in homelessness, the people who are most likely to not be able to afford an apartment in San Francisco are going to be people who have a serious mental illness and are not going to be able to hold a job that will allow you to have an apartment in San Francisco. So it's not that it is mental illness that is causing homelessness. It is that homelessness is going to pick up people, the canaries in the coal mine. I'll come back to that idea in a moment. So people with mental illness, in terms of all these other social forces, get swept along with these mainstream forces. So when we look at what's happened, when we look at what's happened to people who are homeless or incarcerated, you can see that that fraction has also increased with deinstitutionalization. And so while we see improvements on sort of this end, we see real declines on that end. So to recap, mainstream policy changes to date have had very large effects on the lives of people with behavioral health problems in terms of access, quality, out-of-pocket burdens, and living conditions. This suggests to me that focusing on mainstream policy is super important if you really care about the well-being of people with mental illness. So now I want to switch gears and talk a little bit about how mainstream policy has thought about mental illness. And I'm going to talk about efforts at healthcare reform because that's the biggest mainstream policy we have. And I'm going to start with Richard Nixon because he had a health reform plan. Does everybody know that Richard Nixon was an advocate of universal health care? His brother died of tuberculosis. His mother actually ran a small tuberculosis home, so it was very personal to him. We'll talk about Clinton. So the Nixon health plan actually included a mental health benefit. Remember, this is coming post-Kennedy's talk at the height of deinstitutionalization. The plan includes inpatient care limited to 30 days, and outpatient benefits, which are complicated, whether you use a private practitioner or whatever. But my favorite part of this is this dialogue between Senator Bob Dole, and Cap Weinberger. Does that include psychiatrists? Are you going to include psychiatrists in your health plan? Yes, I am told even psychologists are covered. Psychologists. I don't know what they sounded like. Because of mental health coverage, psychologists, mental health therapists, and psychiatric social workers could be reimbursed for services rendered under the auspices of comprehensive health care centers that would ultimately be under the direction of a doctor. So, first of all, a really innovative vision to begin with, right back there in 1970, but also this kind of startling recognition that we are actually going to provide a full spectrum of mental health care. Okay, fast forward about 20 years to the development of the Clinton plan. Richard Frank, my co-author, was one of the people working on this plan. Other people trying to think about a mental health benefit in the Clinton plan. And it is somewhat more generous than the one in the Nixon plan, but it is also on this 30-day, 60-day, 30 more days, additional visits, inpatient benefits are reduced 1 day for every 4 days. This very mechanistic kind of design, very different from the general health program in the Clinton plan. There is a separate chapter in the Clinton health book. There's a book that is devoted to mental health. I forget what it is. I'm missing it in a moment, but there is a book that has the Health Security Act. That's the Clinton health plan. There's a whole chapter on mental health care. So after the Clinton plan fails, the people who worked on mental health policy began to work in a new area, which is this issue of parity. I'm not going to talk about parity very much, except it's a great example of how research, advocacy, and policymaking came together to really focus on exceptionalist policy, the fact that in general mental health benefits are less generous than general health benefits and really provide that protection. So this is the Dominic G. Wellstone bill that says that private health insurance for mental health fails to protect against most serious illness. There's a research study, and there's a bill signed by George Bush, there's Patrick Kennedy, saying we've got to have parity. Mental health benefits have to look the same as general health benefits. One of the things that is a consequence of parity is the Affordable Care Act. I truly believe that if this legislation had not passed, it would have been almost impossible to pass the Affordable Care Act. Because we would have been all caught up in mental health fights. But as it happened, this had already happened. So we didn't have to deal with mental health fights when the Obama reform happens. So here's the Affordable Care Act. For people who work in health policy, how many of you, you're a little bit older than my students. So I now teach students who don't remember 2008. And they take it completely for granted that the Affordable Care Act passed. But it was the most unexpected event for people who worked in health policy. No one anticipated that this thing was going to actually fly, but it did. And from a mental health perspective, one of the coolest things about the Obama reform is that it hardly mentions mental health at all. There is not a chapter on mental health. It almost doesn't show up in the bill. It shows up in just a few places. There is a definition of the essential health benefits, and that includes mental health and substance abuse treatment. Parity applies because it's already been litigated and we don't have to have that fight again. And there are 3 other small references in the whole bill to mental health. This is a completely mainstream piece of legislation. It has no exceptionalist pieces in it at all, parity having essentially taken the exceptional and inserted it into the mainstream. Okay? What does it do? It does a lot of things in the Affordable Care Act. I'm only going to focus on 2, the ones that are the most, I think, consequential and the most controversial and most at risk of being eroded over time, which are around the insurance reforms and coverage expansions. So I actually want to talk about, actually I'll stop for a second. I want to talk about the insurance reforms. So the first part of the Affordable Care Act really focuses on the bad behavior of insurance companies and says, you guys, you private insurance companies, you have to behave better, especially in the non-group insurance market. So the non-group insurance market before the Affordable Care Act is mostly regulated by the states, inadequately regulated on the whole. And insurers in the non-group market can do pretty much what they like. They can accept people, charge them whatever they want, do whatever they like. When people talk about pre-existing conditions, it is the insurance reforms that they are really focused on. That is saying that people who have a pre-existing condition can participate in the insurance market on regular terms. We don't think of this as a mental health issue at all. When you talk about pre-existing conditions, people think about cancer or something. Okay, I want to show you, when I found this, I was so startled by it, maybe you will be too. So this is from Aetna. I pulled it off the web just in time because it doesn't exist anymore. This is probably from 2011, and it's about their risk criteria for enrolling people in non-group health insurance. And it's asking you if you have anxiety or depression, these conditions, including anxiety, depression, panic attacks, PMS, obsessive compulsive disorder, any of those things. How are we going to rate you? So this is for an agent. How are we going to rate you? If your age is, well, let's just take somebody here first. Your age is 40 to 49. You're stable on a single prescription medication. You've never had a suicide attempt. We might just sell you regular coverage or increase your rate by up to 30%. If you're stable but on 2 prescriptions, we would increase your rate by 10 to 50%. Well, what if you're 0 to 22? If you're on 2 prescriptions, we would increase your rate by 20 to 60%. If you're 12 to 18, stable on a single prescription medication, no suicide attempts, no hospitalization, that D means deny. So if you have a family and a kid who is stable, who has anxiety, is stable on a single prescription med, a reasonable thing for a representative would have been to deny you coverage. Now, I'm not calling out Aetna, I just happened to pull their data from the web. I want to show you another study. So this is a study out of Georgetown Law School that was conducted in 2001, and they did like a secret shopper study. So they sent little bios of different people to all these insurance companies to see what the insurance company would say. So one of their characters was Emily. She's a 56-year-old widow who is situationally depressed. 23% of the time, she was rejected for coverage. That was the only thing that was wrong with her. She was depressed because she was a widow. Of the 46 offers she received, 23 excluded coverage for depression or nervous conditions, and 30 of them imposed a premium surcharge. So she was offered coverage at up to twice the standard coverage for the year. So when you think about eliminating pre-existing conditions, and you think about those rare and serious pre-existing conditions, it's probably worth thinking that essentially a 17-year-old with anxiety disorder is a pre-existing condition. Okay, so insurance reforms are actually mainstream reform. Nobody's thinking about mental health. Extremely consequential for people with mental illness. Coverage expansions. Again, nobody is thinking about mental health. It doesn't show up in the language around coverage expansions. The ACA has Medicaid for all under 133%, importantly including childless adults, as well as the other stuff. This requirement is the thing that's in the Texas lawsuit. We'll see what happens. So why does it matter? Let me go back again. Why does this matter? Remember I talked about SSI and SSDI and Medicaid expansions and how important they were to people with mental illness when I talked about the last 50 years. People with mental illness who got on Medicaid, for the most part, were people who qualified for disability insurance, disability income insurance, who had gone through a disability determination process and qualified for SSI or SSDI. A lot of people with mental illness, especially people with less serious mental illnesses, are never going to go through that process. They're never going to try. Maybe they're trying to work. Maybe their illness is not that serious. Many of them are childless adults. This picture is the state Medicaid coverage standards for parents and single adults before the Affordable Care Act. The blue line is 100% of poverty for a single adult. The red line is 100% of poverty for parents. The yellow bars are the coverage standard for parents. So in a generous state like New York, okay, the yellow bar says parents with incomes over up to 150% of poverty are eligible for Medicaid before the ACA. Okay, the red line is what it says that single adults in New York with incomes up to 100% of poverty were eligible for Medicaid. Here is California. You notice something here. Single parents were eligible up to 100% of poverty. Is that California? Yeah. But what do you not see beside the California thing? There is no red bar. You see how few red bars there are here? Essentially, before the Affordable Care Act, you could be as poor as anything. You could have no money at all. And in most states in the United States, if you were a childless adult, you did not qualify for Medicaid unless you could pass a disability eligibility criterion. So for a lot of people with mental illness, the expansion of Medicaid really made an enormous difference. So hard to capture this. We did some analysis of the behavioral risk factor surveillance survey, which allows us to distinguish between expansion states and non-expansion states, but does not have a good measure of mental illness. What we're going to use is a measure that asks you, how many days in the last month did you experience poor mental health? All right, so the people, this is the none. This is the uninsurance rate. You can see overall, the uninsurance rate among people with no mental illness has fallen quite a bit. And then you can go up. The purple are people who spent more than half the month having poor mental health days. And you can see that that fraction drops a lot. Doesn't drop very much in the non-expansion states. It drops by over 50% in the expansion states. So you see people who are experiencing serious mental health disability and are finally getting coverage when their states expand Medicaid. We looked at health insurance coverage of the population, and you can see for those with serious mental illness, Medicaid is an extremely important part of their coverage. 12% uninsurance rate in 2017. The uninsurance rate before the Affordable Care Act was somewhere over 20% for this population. So those benefits, and if you look at the private insurance piece of this, the thing the Affordable Care Act does is impose parity on that entire population. So we also see improvements in mental health service coverage for people with private insurance. The final piece of this, which I think is not great, are performance standards for mental health coverage. So this is the piece that I think that we do not do a good job on, and it's a great piece for research, because in order to do a good job on it, somebody has to know what it means. And we don't really have a good sense of what it means. So there are really lousy measures for mental health in the assessment of commercial health insurance plans. Did you have a follow-up after a hospitalization for mental illness within 7 days? My colleague Howard Goldman says you could train a chimpanzee to do a follow-up for mental illness after 7 days, and you would qualify for meeting the HEDIS measure. You could just have a robot calling people and asking them whether they're home from the hospital after 7 days. So we do not have great measures here. We do not have great measures of network adequacy for mental illness either. And a lot of what we are seeing is we rely on providers to, insurance companies and providers to respond to the coverage requests, coverage demands we have out there. We don't have ways of assessing whether they're doing that, and so we see big gaps in coverage. So one of the things you hear in the San Francisco proposal this morning is lots of people, even with insurance, can't get access to mental health. It's not exactly clear to me how this proposal is going to change that, but that concern is a function of the fact that we do not have a good way of saying to insurance companies, you are not providing adequate access for mental illness. And that goes back to the lesion problem. Who needs this problem? Who needs this care? How are we going to determine that? One last thing on this coverage thing before I switch to one last area of research. And I don't know how many of you are familiar with this. Are you familiar with the Oregon Medicaid lottery? Okay. It's a great story. Okay. So if I came to your IRB here at UCSF and said, I want to do the following experiment. I want to take several thousand people. I want to give half of them health insurance, and the other half are not going to have any health insurance. Is that okay? They would say no. So there's really never been a randomized trial of the effects of health insurance. My colleague or co-economist, Amy Finkelstein, was driving her kids to daycare one morning listening to NPR, and she heard that the governor of Oregon had run out of money in his Medicaid program. They had wanted to expand Medicaid. And most states, when they run out of money in their Medicaid programs, at that time, would have a waiting list, and they would just let people on the program on the waiting list. But the governor of Oregon was kind of a cool guy, and he decided he was going to have a lottery. So if you wanted to be on Medicaid, you had to submit an application, and then they were going to draw from a lottery. And Amy, pulled her car over to the side of the road and was like, it's a randomized experiment in Medicaid. She very quickly got a lot of foundations to give her money. She teamed up with a great group of people, and they studied what happened to people when you gave them Medicaid. So this is the Oregon Medicaid lottery. 56% of the people in the Oregon Medicaid lottery screened positive for depression at the time of the lottery. They had, on average, 18 days of good mental health a month. So this was a population with pretty serious mental distress. So they do an intent to treat analysis based on the lottery. And what happens? There's a big increase in visits. There's a big increase in prescription drugs. There's a 10% relative to the mean reduction in depression. That is a big effect. A 10% reduction in depression. 2 additional days of good mental health a year. Okay, is this evidence of the amazing power of SSRIs? No, it turns out not to be. Because most of the effect happens before people even get to the doctor. It turns out that feeling really rotten and not having any way to pay for going to the doctor is a good way to feel even more rotten. So insurance in itself turned out to be a very effective treatment for mental health, and it was, of course, compounded by the fact that people were getting decent treatment afterwards. So providing people with health insurance is probably the single most simple policy advance in terms of treating mental health we have. Okay, what's next? So I wanted to close with the research that I'm thinking about we're doing right now, Richard and me, and I'll speak a little bit from our most recent results, but they are really, really most recent, like a week ago. But I want to start off by contrasting what I just showed you, which is a story of progress and access and all of that good stuff, with some disturbing statistics. So this is also off the BRFSS, and this is what are people doing depending on how many poor mental health days they had in the past month. So you can see that that people with a lot of mental health days, bad mental health days, are less likely to be employed. They're also less likely to be kind of retired or go at school. They're in this category called other. They don't even know what they're doing. We don't know what they're doing. The survey has no categories for them. They are not included in the standard activities of our society. So we have this problem of social exclusion, essentially, of people with serious mental illness, despite the fact that many of them are getting treatment. Many of them, and most of them have access to treatment. And we have this panoply of social services and so on available. When we look at that other, we were interested in breaking it out by what might be wrong with you. This is coming off the National Comorbidity Survey. And what's kind of really telling here is among people with no disorder, about 7.5% of people fall in that other, we don't know what you're doing category. And in every single one of these disorders, you're seeing much, much higher rates. So across the spectrum of mental illnesses, people are less likely to be engaged and functioning in society. And I like voting as a great measure of political participation, and it's also in the General Social Survey. So again, this days of poor mental health is a nice indicator of how lousy people feel. And you can see that people who are spending a lot of days in poor mental health are much less likely to have voted in recent elections. We see rising work disability, more disability benefits recipients, which is good because people are getting income, but it's also troubling because if I were telling you this about some other illness, you would say, well, why aren't we're giving all these people all this treatment? We think the treatment is working. Why aren't they able to engage in the workforce? What's going on? So this is non-elderly recipients. So here's the challenge. Mainstream policies have been really important in improving the lives of people with mental illness, but mainstream changes have also increased the challenges for people with mental illness over time. And I gave you an illustration of that when I talked about incarceration and homelessness, housing affordability, and the problem of people who are at the margins, the most vulnerable, the canaries in the coal mine. That problem actually extends further in society. So this is how we're sort of thinking about this, and you can, I'm very open to your ideas about it. You might think about somebody having a diagnosable condition, and they're going to get treatment depending on the quality and accessibility of treatment. And then that treatment is going to affect their functioning depending on how their social and economic supports are happening. So what is happening, we've improved the quality and accessibility of treatment. Apologies for the bad PowerPoint. We've improved social and economic supports. We have improved the number of people who are getting treatment for their conditions. But social and economic conditions are changing in a way that is really limiting people's ability to improve their functioning. In what way? Well, this comes from the NAMI website. A mental illness is a condition that affects a person's thinking, feeling, or mood, which may affect people's ability to relate to each other and function every day. And this is from the World Economic Forum, the folks at Davos, about what skills do you need to prosper in the new economy. Notice the complete disjunction here. So Richard and I have been looking at that disjunction. We actually have information about the characteristics of jobs and the characteristics and looking at the kinds of jobs held by people with serious mental illness. And it's going to come as no surprise that these characteristics, jobs that have these characteristics, are not held by people with serious mental illness. Now, what's disturbing, these are the jobs that we see growth in the future. So where do we hold on? How do we hold on to the gains? Number one, people got to expand Medicaid. If we want to get insurance coverage to people with mental illness, if we want to improve people's lot, the most important thing that can happen is to keep hold of those Medicaid expansions and extend them. We need more of the things that we have been doing now, more supported housing, more supported employment, better, faster, earlier, more case management. But we really need to work on this mismatch between what people need to be doing in the future and this kind of canary in a coal mine population. So I think I'm right on time. Thank you.
Questions, discussion, please.
Yes.
Such a focus on increasing access to coverage and insurance, and you can see all the benefits from it. But what about this issue of access to coverage but not access to care? So in our system, in Kaiser and all the public systems, the coverage is going up, but care cannot meet the demand. So what ideas do you have where we can work in that part?
So I should first note that access to care has improved. It is true that there is a lot of unmet demand for care, but there also have been gains in actual access. So I don't want to suggest that we hit this kind of wall and we expanded coverage, but nobody got anything for it. That's not the case. In fact, most of the studies on Medicaid patients' access have been fairly positive. And I would say mental health is the only field in medicine, for better or worse, where we actually deploy significant numbers of non-physician professionals. So we have clinical social workers, we have psychiatric nursing, we have general practitioners providing a lot of mental health care. And that's a good thing. I mean, that's a good chassis on which to build. What I think from a research perspective, and the research probably has to precede the advocacy here, is trying to think about how to sensibly ration is a terrible word, but sensibly allocate care. So we do have this kind of pyramid structure with lots and lots of mental health professionals at the bottom of the pyramid, and actually it's quite easy and cheap to train licensed counselors or whatever. This is not a problem. But we do not have a very good system for allocating which cases to which treatments. And it's compounded by the fact that in the history of mental health, and with no negative intent here at all, with no prejudice, there is a group of people who are not very sick, who do not have severe functioning, who are willing to pay very large amounts of money to have people at the very top of that pyramid spend large amounts of time listening to them complain.
Right.
Which is fine, but it means that, which is great, and it's good for everybody who's in that world, but it does mean that we really have an inverted pyramid. The people who are the sickest are being treated by the people with the least, not always. I mean, I don't mean to say that entirely, but there is this problem that you have all these psychiatrists and psychologists out of network who are not willing to participate in insurance plans because the pay is partly because the pay is very low and partly because the outside opportunity is very high. There's lots of primary care physicians who get paid very little, but they have nowhere else to go. Psychiatrists have this other stream. So I think we really have to think as researchers about how to, because insurance companies are not going to figure this out for us in a way that we will be satisfied with. How to figure out what is adequate treatment, who should be getting which treatment. You would not be happy if the prime cancer hospital were dealing primarily with the most simple cancer cases. That would be a mismatch that would not be seen as desirable. We need to make, and I think we do have this very extended pyramid, so I think that's what I'd say, yeah.
I have a comment and several comments. So the first is that I'd suggest a revision to the title of your book. And I realize it's most popular. Something like less horrendous but still shameful. One of the reasons, I have really strong reactions to what you presented here in a number of ways. One is, I'm sure all the data is highly rigorous. But the reality, I think, for providers is borders between sort of horrendous and shameful and unbearable, even for the quote-unquote easily trained, low-paid providers. And so, and I do think, I don't know how many people are working in any of our community-based programs, but the notion that you can have consistent contact with that system and come away with better but not well seems to me sort of a potential misapprehension of the scale and the challenges we face, which then, I feel like I want to have a debate with you. The notion that the baseline ought to be institutionalization and saying that, well, we can show that we're doing better and there's this faux argument that everything's gotten worse because of deinstitutionalization, I think everyone in the room would probably be willing to stipulate that isn't the case. So I do worry that there's an issue of the difference between identifying differences and identifying clinically and meaningfully relevant changes. And I worry that, at least as a practitioner and chair of the department, that when I look at your data, half the things that you suggest are reflecting this better but not well. Yeah, they're definitely better, but again, I think the underlying issue for people who touch the system, regardless of their socioeconomic status, is its health.
Okay, so let me go back. All right, so this is the reason this was the reason that we wrote the book in the first place, and actually a lot of it, we actually wrote some of it in San Francisco a while ago. And the reason we pitched it the way that we did was actually strategic. And the reason it was strategic is if you believe that nothing that has happened in the past 50 years has meaningfully improved the lives of people with mental illness, right, then you have to give up on policy. So what we were saying is policy can improve people's lives. It really can. We have tools that we can do something with. We can actually improve people's lives, and therefore we need more of this. Because if you say Medicaid, forget it, it's terrible. Medicare, those people are not getting good services. Private insurance is a mess. The expansion of supply, we've got a lot of people out there, far more people. We have a whole chapter on supply. There are far more practitioners, but they're all overloaded. Everything is awful. Then, if I go to congressmen and say everything is awful, everything you've ever tried is awful, everything fails, it doesn't work, they're going to say, let me work on something I can solve. So I want to say, no, we have made a difference. We have made meaningful differences. If you look back in the 60s and 70s and 80s at the lives of people with mental illness, if you look at newspaper accounts of how people were living and the numbers of people in different situations, we have made meaningful differences in people's lives. Does that mean that things are well? It absolutely does not. But should we give up on the experiment of policy? No, I don't think we should.
and works on this. And so I think the notion of accepting the scale of the challenge now, that somehow is going to lead to people throwing up their hands and say that it can't be fixable, that you're talking to a different audience, and I understand for policymakers that you might want to pitch, although I also would, again, question whether or not sometimes that can be overly strategic because essentially you turn off or potentially lead people to believe that you don't appreciate the scale of the challenge that remains. But part of this is one is obviously for, as being the chair of this department and struggling through trying to help take care of the most severely ill in the city and the region. So it is partly that I really do believe deep down inside that our approach continues to really border on shameful. But more importantly, I think that it's masked in some ways by a lot of the data that you provide, the level of shame that I think needs to be brought to bear, along with some sense that there is a positive path forward. And I think that those two things may be able to live side by side. But very specifically, one of the things that really struck me in this slight shift is that my experience. And by the way, I'm a molecular geneticist, so I have no idea what I'm talking about. Except I'm responsible for this department at some level. Is that the one thing that I experienced really profoundly with the shift to Obamacare was that all of the focus on sort of short-term Medicaid expansion, parity, the pre-existing parity, would, by the way, Patrick, be the first person to tell you that parity is like almost in name only, and he's had to spend all of this time.
Yeah, he's not right, but anyway.
But, at least he's on. You got a picture of him, so I'll take him on my side of this argument. But the issue is that the biggest change for me, and I think for us in this place, had nothing to do with that. What it had, or little to do with that. What it had to do with was the significant structural shift that large healthcare systems saw in terms of where the future of this was heading. And so all of the kind of short-term stuff is great, and I agree with you, it helps. But the thing that really changed is that we went from being absolutely at the bottom of the list of priorities in this and every other institution nationally to being at the very top of the list.
I took those 3 slides out because I thought I didn't know. Yes, I agree. So let me just,
Carve out from you and your thoughts
Yeah,
about the carve out, because that is kind of more exceptionalism a little bit.
Yeah, so that's an interesting, so lots to say about carve-outs. One of the reasons that parity happened was because of carve-outs. So the reason parity hadn't happened is that the literature prior to parity, which was pretty robust, suggested that if you made cost sharing for mental health the same as cost sharing for general health, you would get a doubling in the use of mental health services. So mental health service use is extremely responsive to price, much more so than general health. So the entry of managed behavioral health care actually allowed parity to happen. It would not have happened. That's why the Clinton people could not get it through. Now, it created a set of issues of its own, for sure. But that's why it happened. Now, one of the things that has happened over time is that we've sort of seen more carve-in and ACOs and all sorts of delivery system reforms. But the tools of managed behavioral health care, which were really about triaging people, and those have remained, which I'm not even, for better in the sense that they gave us parity, for worse in the sense that we do not have great metrics for measuring them. Yeah.
I'll make it very quick. Thank you so much for a provocative presentation. We're not exceptionalists anymore. So on behalf of the providers who are sitting here and all those who can't be here because they're in clinic, we work in teams as embedded psychiatrists and psychologists. So I was wondering, the reimbursement still is an individualistic per patient RVU. But are there economic models that look at the contributions we bring in decreasing morbidity and mortality overall in health systems? And 2, when will these models hit the insurance companies so we can actually be recognized for the care we actually do?
So I'm going to say something else. I shouldn't really walk out here on a bad note, but I'm going to. Okay, hold on. Okay, good. So here is the sad truth. Mental health services do not save money. They make people better. They make people much better. They make people with cancer better. They make people with heart attacks better. They make them feel better, and they make them function better. They don't save money. And if we keep going, if we keep going down the path of saying we want to get, so I am waiting for the day when someone will tell me, we need to pay more for cancer care because it reduces people's depression when you treat their cancer. And when that day comes, I will be delighted because people will basically be saying mental health is a condition that we need to treat. Somebody who is depressed deserves treatment just like somebody who has cancer deserves treatment. Not because it reduces the cost of cancer, but because they have an illness that we need to treat. That is, and we should not, as mental health people, fall into the trap of believing that we are ancillary care for cancer patients. That's wrong, and it's not going to serve us well. Right? So that's statement one. Statement two, there are health systems and models that pay team-based care. They haven't caught on for a variety of reasons, but some places do it. I am not sure that they buy you as much as you hope they buy you.
On that happy note.
I got one more person in the back. Sorry. You could just ask your question.
Cost issue. I think it's because we've been very narrow-minded about how we measure the cost. If you look at the whole system and look at things like length of stay, just a simplistic thing, if we measured that, I think we would find that mental health treatment actually does save care. We know that mental health patients utilize more care in systems in terms of cancer and, primary care and all that, but we don't measure it. So I think the time for us saying that it doesn't save money, we don't know whether it saves money or not because we're not measuring it appropriately. So
I think we could always do more research in this area. So let me close with that.